much, and I'm very glad to be here along with so many giant neurosurgeons. I am very honored and very pleased to present my concept regarding the importance of basal system in the development of skull-based meningiomas. I have no conflict of interest. I am only in conflict with neurosurgeons who avoid to operate. And my single interest is to promote, along with all the colleagues we have here in this Congress, the real micro neurosurgery. So there are two prerequisites for my presentation. One was offered by Professor Yassergil, that mentioned that meningiomas originate in the subdural space and extend subdurally, but epiarachnoidal. They are covered by two or more cisternal layers, depending on the number of the cistern traverse. And the other one, it's given by Osama Al-Mefti. Arachnoid is the best ally of neurosurgeon. So we know the basal cistern, they were described by Kay and Ratius, and this is maybe the most detailed anatomical description made by these two authors at the end of 19th century. And the fact was also underlined by Professor Yassergil, who mentioned that we discovered this only after the introduction of microscope. These are drawings made by my son, Alex Florian, who is also a neurosurgeon. And I saw that these arachnoidal membranes have certainly a role. I studied a lot of cases, and I have a quite large experience in meningiomas, more than 1,800 operated meningiomas. So I observed that the limitation of the meningiomas into a specific system is demonstrated by the similar aspect of the tumor for at least a period of time. The membranes and other arachnoidal structures, along with the neurovascular structures, will conduct further expansion of the tumor. So if you look to these similar aspects of the tuberculum cellae meningiomas, doesn't matter where they were published. These are from my series, or these posterior fossa pectoroclival meningiomas in different positions, quite similar aspect. And this is given by the content of the tumor into the specific system for at least a period of time. For example, for meningioma located at the planum sphenoidale, which is covered by a slack and more lax cistern, they can grow anteriorly and superiorly, but rarely they penetrate the optical chiasm. So their development in the posterior part, it's only later on. But contrary, for the meningiomas located at the tuberculum cella, because of the membranes they are covering, they tend to develop anteriorly, superiorly, and posteriorly, and they are pushing back the optic nerves and the chiasm. They compress and up toward an upper position the vascular complex of anterior communicating artery, and sometimes they can go into the optic canal, but usually the lamina terminalis limits their progression into the interpeduncular system. Similarly, for the posterior fossa petroclival meningiomas located mainly in the cerebellopontine system will develop in time in this system. Those, and you can see, located lower a little bit in the cerebellomedullary system will remain for a period in that system. And again, for those located in the region of foramen magnum, and especially in the anterior part, in the prepontine system, they will develop posterior, they will compress posteriorly the brainstem, and all the vascular structures are displaced laterally. So based on this concept, we also proposed a new classification of posterior fossa, and especially sphenopetroclival meningiomas, based on the system they are occupying at the moment, in the moment of their diagnosis. So sphenopetroclival meningiomas, it's clear, but those located in the prepontine system could be named prepontine meningioma. Similarly, cerebellopontine meningiomas, posterior. Those located most posterior outside the system could be posterior petrosal meningioma, cerebellomedullary meningioma, premedullary meningioma, and those located in the posterior and cisterna magna meningioma. We published this classification, but unfortunately doesn't get the adherence I hope at the beginning. So this concept of developing and into the system and covered, all the structures are covered by at least 2 layers of arachnoid. And the CSF, it's acting like a lubricant. Once you remove partially the tumor or debulk the tumor, you can see, and it was already demonstrated by previous speakers, Dr. Alda, Dr. James Liu, that once you remove partially the tumor, you can mobilize. And this is because of the arachnoidal layer and the arachnoid and the CSF, which are acting like a lubricant for the tumor and also for the neurovascular structure. So this concept of transtumoral route that was developed by Professor Sami, and also navigating the system, offered the possibility of a less invasive approach, especially for anterior skull-based meningioma. We are now using only frontolateral approach, subtemporal or retrosigmoid for those located in the subtemporal for middle fossa, retrosigmoid, lateral and medial suboccipital. This is our classical opening. So for anterior skull-based meningioma, like in this tuberculum cell meningioma, we are using the frontolateral approach. We are going directly to devascularize the base of the tumor, and then after the devascularization, reducing progressively the tumor, we can I don't know how to close this window. We can reduce, and you see, by reducing, we can mobilize the tumor. Tumor creates its own space. We should take advantage of this. Don't make large opening. A proper positioning of the patient, of the head of the patient, offers you enough space to reach the base of the tumor, and then by devascularizing, progressively reducing, you see we can completely remove the tumor with a very small opening. And in similar manner, we are using the frontolateral approach for this large olfactory groove meningioma without any difficulties. So going to the posterior fossa, as I already presented, this kind of tumor could be all approached by a retrosigmoid approach, like this, quite large, with a supratentorial extension, but we are using in the posterior fossa lesions the sitting position. And this offers you a lot of advantages, because once you reduce the tumor will fall down, and you can only mobilize the superior part. Sometimes you can also cut partially the edge of the tentorium in order to enlarge the space, and with a fine traction and with the gravitation, the tumor will fall down, and you can, without large bone resection, you can remove the tumor. And I re-underline, in sitting position, it's possible. I was impressed by the presentation of our colleague James Liu, how nicely he opens. But if you have this opportunity to put the patient in the sitting position and having the gravitation along with you, you can remove completely even large tumor, and even cases with trigeminal neuromas extending in cavum-metallic. All kind of this kind of tumor can be safely removed without too much bone removal. So this is another case in which we can also use the retrosigmoid, but not only the retrosigmoid root, classical, but also the supracerebellar one. In sitting position, you can see we can identify early the nerves. We can preserve the veins. You see here, they're the fourth nerve, and he is covered. This nerve is covered by the arachnoidal layer proper, and we can preserve it unto the end in sitting position with the supracerebral, retrosig supracerebral approach. It's quite easily, and this is what I learned from Professor Benesch. He usually use this for most of the petroclival meningioma. So you can see a complete removal without damaging the patient. And for the posterior fossa, meningiomas depends on the location. If it's in the premedullary cistern or in cisterna magna, we are using this midline approach. But keep in mind that tumor creates its own space. So if once you have a small opening at the surface, you can take advantage of this, and you can debulk tumor. Go in this case, in this particular case, you cannot devascularize from the beginning, but usually these are not so hemorrhagic. So once you have a hole of the tumor, you can reduce it by different means, using this was a more consistent tumor, but you can use whatever instruments you need and go along with the tumor. You can reach the base of the tumor and then coagulate, and taking advantage of the arachnoidal layer, you can completely remove. And this is, I also use the midline approach for this particular case with bilateral extension of the tumor. In fact, the medulla was engulfed by two extension of the tumor. With the midline approach, simple classical middle approach, understanding the role of the arachnoid and taking advantage of the space created by the tumor itself, and remembering that all the structures are covered by the arachnoid, proper arachnoidal layer, you can remove completely from one side and then move to the other side, identify the nerve, dissect them, and finally protect them. And then we can completely remove this tumor, as you can see in the control CT, without any neurological deficit. So summarizing, in skull-based meningiomas, there is no place for dogma. If for the same location there is more than one possible way, choose the most appropriate according to your experience. The first surgical intervention offered the only opportunity for complete tumor removal. Is the single occasion we have when we have all the arachnoidal layers covering the tumor and also the vascular and nervous structures. Do not always be radical, as it was already mentioned. Sometimes it will mean that you will be radical with the patient. And the take-home message: the tumor creates its own space. Take advantage of this. Remove the tumor instead of bone. It's easier even for the patient. And surgery of skull-based meningioma is not simple. Do not complicate it additionally. And look at this. These are some cases. This is statistics. Neurosurgery is not only statistics. Behind every single image, there are a unique person. Treat her or him with the diverse, deserved uniqueness. Thank you for your patience, for invitation. I'm glad to respond to any questions you have. Thank you.
Thank you, Dr. Stefan, for